Excellent. Thanks so much. Well, thanks you everyone for joining me here on this very early Friday. So I am Lulu Zhao. I am a OBGYN. I've been at University Hospital for about 15 years. I am currently making a transition to a different institution come next month. But I am also addiction medicine certified, and I specialize kind of in my field in women's mental health. So I'm really excited to talk to you guys about this topic, which has really been something that I learned a lot about myself in my own career. And so hopefully I'm sharing information that's useful for you guys. Let me see if my screen share is working. Can you guys see my screen share right now or no?
Not yet.
Let me
You'll
see.
have to reshare it.
Oh, okay, I have to reshare. Okay, I was gonna say
Thank you.
no worries. Let me share that and maximize that. Okay, now can you guys see it?
Yes.
Okay, great. Excellent. All right, let me just pop my okay. Uh, Uh-oh, did I unshare it? Okay. Um, am I advancing or are you advancing right now, Kara? Or did I unshare somehow?
No, we see him
Oh, you
present.
see it. Okay. Okay, great. So those are just my credentials. And so one of the ways I learned so much about this topic about child welfare referrals is that when I was at UH, I was leading a clinic called Rise Clinic, which is a interdisciplinary clinic for pregnant women who had substance use disorders. And I would say, like, historically, most clinicians do not deal with the child welfare referral part of the equation. You know, we provide our medical care and then we let other people, like social workers, kind of handle that aspect for us. And I think my personal belief when I started doing this work was that, oh, like, everyone kind of has the same fund of knowledge as I do and would come to the same decisions as I would. And, CPS is kind of like a safety net to catch things that maybe I wouldn't catch. And, um, the outcome is going to be what I would expect. And what I've learned, unfortunately, over time is that that is rarely the case. And that, I really have have a pretty big role in whether or not patients get referred to DCFS. And I really, I'm just one person in a hospital system, so you can't always just do everything that you want to do. But I've really gained the knowledge, I think, to think more critically about whether or not what I'm doing is helpful to the family unit or whether it's harmful. And that's some of the info I want to share with you today, too. So the goals for today's talk are to kind of critically interpret the data regarding the harms of substance use during pregnancy, to know the law regarding mandatory reporting in the setting of perinatal substance use, and to recognize the impact that clinicians have on DCFS investigations. So about 21 million children in the United States live with a parent who has misused substances in the past year, which is a staggering amount of children. And 1 in 8 children live in households with at least one parent with an actual diagnosed substance use disorder. Now, I think most people with good intentions are very concerned about the impact of parental substance use on children, in addition to the potential harms of the in utero exposure during pregnancy. Households with a parent with an active substance use disorder are more prone to be exposed to violence and trauma. There can be a more chaotic and unpredictable home life. And sometimes parents themselves, due to either intoxication or some of the comorbid medical conditions, are not really able to respond to children the way that you and I would ideally respond to our children. There can be an increased risk for true child maltreatment or abuse. And sometimes, in the best of circumstances, say no, nothing abusive is going on. Sometimes parents who use a lot of substances really normalize that behavior for children, and they themselves might be more prone to use substances too. So I don't think anybody really contests that there are risks with using substance use, in a pregnant patient, and what that might mean for the child. I think the real question, though, is whether or not the harms that are caused rise to what we would consider to be child abuse, right? And also whether or not their appropriate response is surveillance by DCFS for patients and families who are at risk. So I'm an OBGYN. That's my background. So I think, a lot of times what I see is that there is this very vague notion of the fact that drugs are generally harmful to babies. And I just want to dive a little bit into the data that we do have and to try and give you some quantifiable numbers to use and to kind of put things into perspective. So when we think about substance use disorders in the mother-baby dyad, these are probably the four main categories that people think of when they think about potential harms. So that would be, major congenital malformations, or what most people think of as birth defects, the impact on the placenta and therefore other obstetrical outcomes, such as preeclampsia, growth, preterm birth, etc. The impact on the baby's brain development to be exposed to drugs in utero. And then really, I think this is the big one, but we just don't have data on that on somebody who's pregnant, is continuing adverse postnatal environment.
Oh.
So let's just talk about birth defects first. As you might recall from med school, and some of you guys just really disclosed that you went to med school a very long time ago based on your cost of tuition. But as you might recall, when we talk about congenital malformations or major birth defects, these are malformations that predominantly are going to take place in the first trimester, right? So you were exposed really before 8 to 10 weeks of gestation, where all your cells are moving around and forming and they're all pluripotent and changing into things. That's when the exposure happens and causes congenital malformation. And this is the rate of unplanned pregnancy or mistimed pregnancy in the United States is almost 50%. So most people who have a substance use disorder are in fact going to be using drugs in the first trimester because they don't even know they're pregnant yet, right? Ones with an active substance use disorder. And so there are some suggestion that there could be an increased risk for some congenital malformations. And I'm sorry, under alcohol for cardiovascular, it should just say 2 to 3, not 22 to 3. There are some plausible mechanisms by which that could happen. But the key thing that I want to emphasize here is that the absolute risk of major malformations is very low because the baseline prevalence of having a major malformation that's going to significantly alter your quality of life is low. Okay. So when people say like, oh, birth defect, you're going to have double the risk of having a heart defect with alcohol. I mean, that's technically true, but that still means that your risk of having a heart defect is like 7 in 1,000, right? So it's not like everyone who's used drugs is going to damage their baby because statistically that's not even likely that their baby's probably, you've seen this. People use drugs, get no prenatal care, babies are totally fine, right? So again, I think it's really important in medicine to think about what is a relative risk and what is an absolute risk, especially when you're talking about conditions that end up being used to demonize the parent as kind of irreversibly harming their child. The second area is placental dysfunction. And this, I would say, is much more well demonstrated in the literature. It is, when you look at studies, there is very plausible mechanisms for how substance abuse can affect the placenta and cause the placenta to not function as well. And the main thing you're going to get out of that, which is the main thing you're going to get anytime the placenta is not functioning well, is growth restriction. And growth restriction is defined as the baby is less than the 10th percentile of their population, right? So a 39-weeker who would be smaller in size compared to 90% of other 39-weekers. And the risk of growth restriction does vary by the substance used. And again, let's think about relative versus absolute risk, right? So with alcohol, it's about a relative risk of 1.2. So 12% of those babies will be growth restricted. Cannabis, maybe around 1.2 to 1.4. So it's 14% of those babies might be smaller in size. Opioids 2.9 or 2.09, so about 20% of those babies might be growth restricted. And then the highest risk is probably with your stimulant use disorders, so about 2.5 to 3.5. And when you get to 35% of babies being growth restricted, that is more significant. But again, growth restriction is not death. It is not a permanently disabled child. In fact, if you look at most studies of growth restricted babies over time, they actually are not growth restricted children, like or adults. And in fact, sometimes they're actually end up becoming obese children or adults. So there are harms. But I think a lot of people, when people hear like, oh, the baby's growth restricted, they think of this like weak little baby that's in the NICU and it's gonna, be all shriveled up and not survive. And that's not really the definition of growth restriction universally, right? That's more like a growth restricted preterm baby, and those, do have higher risks. So that's just, this is what growth restriction is and what it is not. So it is a harm. It's something I definitely talk to patients about. But again, it's not like you've permanently created this super disabled baby, right? Just because they're growth restricted. This, I think this kind of made a big splash. I think this article came out in 2023. It was this thought that fentanyl exposure can cause like a syndromic effect in babies. And there was all these headlines about like fentanyl babies and, fentanyl birth defect. And what I would say is that I do think the syndrome is probably real, but it's very specific, So the headlines would make it seem like if you use fentanyl, your baby's going to have a small brain and it's going to, essentially be like an FAS baby or something like that. And really what this is a case report from a geneticist who noticed that there were a couple of babies who kind of had the similar morphology. They had certain findings at MRI, like, maybe um, absent corpus callosums and things like that. But again, this case report initially was just 6 babies. And since then, other people came out. But, I think the total number is under 100. And what I think they really discovered is that for certain people with a particular genetic mutation that affects cholesterol metabolism, use of fentanyl during the pregnancy can cause carriers of this mutation to have abnormal cholesterol metabolism, which then leads to some of these findings. But the cholesterol abnormalities correct after the babies are born, right? It's not like they're permanently have alterations in cholesterol metabolism because it has to do with the fentanyl exposure impacting certain pathways in cholesterol synthesis. And it also, this is so new. This was just, kind of quote unquote discovered in 2023. We don't really know the long-term sequelae, like people think, oh my God, you're missing a part of your brain. But, as most of us in OBGYN know, like an absent corpus callosum doesn't mean there's no definitive finding of what that's going to cause because brains are very neuroplastic. And there's probably a ton of us just missing our corpus callosum and we don't know it because we've never been scanned. So, I do think this is a true disorder, but I don't think it's like the fentanyl baby syndrome, where like your baby's again permanently disabled. Right? You're still learning about stuff like this. Okay, so real but rare. And then postnatally. So I think one of the things that is very common for people to attribute anything negative that happened to a baby after birth, when they were substance exposed in utero, anything negative that subsequently happens is then attributed to the substance used by the parent. And I would just like to say, from a scientific perspective, we don't know that. I mean, it could be, that some of the harms you're seeing are related directly to the substance use, but also there are so many other things that are happening post-birth, right? So were they born preterm? Well, preterm infants in the NICU undergo a lot of painful procedures in the ICU. And so did they receive substances like opioids just as part of their prenatal, part of their care, right? Is that influencing some of the neurodevelopmental things that you might see? Was the baby even under the care of its mother after birth? A lot of times these babies are removed or in the care of other guardians. So when you say like, oh, this baby little Johnny had ADD and, is very externalizing behaviors.
Mm.
I think people blame the mom. Well, that baby's mom used, drugs when she was pregnant. But maybe part of the reason little Johnny has all those behaviors is because its postnatal environment with somebody else was not good, you
Mm.
know? Also, I think we see this all the time. One of the reasons substance use disorders are so tricky is that you don't really know who has one. We like to think of the stereotype of people who have substance use disorders, but there are a lot of people who are out in the world, functional, highly successful. You have no idea they have a substance use disorder, right? So I think the same thing applies to parenting. There are people who have substance use disorders who are actively using totally appropriate parents. They're showing up to school with their kids. They're
Mhm.
helping their kids with homework. Their kids are well dressed, well fed, totally well nourished. They were able to parent despite their substance use. So again, we got to be careful about stereotypes of this population.
Mhm.
And then finally, if the child did have some sort of neurodevelopmental harm from substance use, which again, there are some studies that indicate like they might be more prone for ADD and things like that. I'm not saying it's zero, but so much of that prognosis depends on were they diagnosed? Were they appropriately treated? Did they have the privilege of being in an environment and society that supported them and helped them overcome, right? Because children have neuroplastic brains. So again, very, very complex about whether or not a child who is substance exposed does well or not later in life. And I just think we should be very careful about blaming any deficit on the fact that the parent used drugs during the pregnancy. Just to reiterate the point that substance use is not equivalent to poor parenting. Sometimes it is, but that is not a universal truth, right? So like I said, if it's so obvious that someone is impaired and has a substance disorder, why would we use universal screening? We should just be able to look at everyone and say, you are clearly using drugs, right? And, sometimes people are using, but they don't actually have a substance use disorder, right? That we know in the field of addiction is a thing. Do we count for the severity of a substance use disorder? Some people have mild substance use disorder, some people are severe. Obviously, that's going to be two different impacts on parenting. And then what I see this a lot in OB-GYN is, sometimes parents who have an active use substance use disorder, they know that they're not fit to parent while they're intoxicated. And they don't parent. They make arrangements. For example, they might be co-parenting with another bio parent and they use when the kid's not in their custody or they send the kid away, they're using cocaine when their kid's at a sleepover, so I just think again, people want to be good parents and we can't make assumptions about, oh, you're positive for this drug, therefore you're just high as a kite around your kid, right? Because we don't that's actually not what happens in reality a lot of times. And finally, I just want to put into perspective these risks on birth defects, growth restriction, preterm birth, neurodevelopment, et cetera, against other chronic diseases. Okay, because a lot of people really, I think, have a special carve out in their brains for substance use disorders and other psychiatric disorders in terms of parenting fitness and whether or not it harms the child. And I would just point out that most chronic diseases have the same potential to harm a child, right? They can all cause congenital malformations, growth restriction, preterm birth, neurodevelopmental problems. And so arguments that a mother has somehow kind of uniquely and irreparably harm their child due to substance use is really not based on scientific fact. Okay, it is just like any other chronic disease. And I think, moreover, arguing that specifically women with mental health disorders, such as substance use disorders, need to be civilly or criminally punished for kind of obstetrical things that happened, like a miscarriage or preterm birth, is discriminatory, right? Because a lot of other diseases cause these same harms, right? We're not removing children from type 2 diabetics who refuse to take insulin and enter DKA and deliver preterm. Like, we don't do that. And so it's really a discriminatory approach. So one of the questions that we are faced as clinicians is, do we report or do we not report? And I guess I use we kind of collectively, because as John points out, usually it's the social worker who has to report, but we lead this train, we are starting that process. And what I would, my personal experience that um, clinicians are often given guidance based on local culture, hospital precedent, et cetera, that are discordant with the actual law. And we don't even know that it's discordant with the actual law. So this picture up on the side here is a screenshot from a pamphlet that DCFS used to give everyone. I don't know if it still exists, but it would say like, this is, you have basically indicating like, you're a mandatory reporter. If any of these things happen, you have to report. And this pamphlet is, legally speaking, wrong. Okay, so what does the law say? So here are the federal statutes that kind of govern child welfare reporting. And then, of course, in addition to that, you're going to have state law, case law, and like kind of institutional policies. Okay. But the first major thing that kind of governs child abuse reporting is CAPTA. So CAPTA was created in 1974, and it requires states to create laws, and it can vary by state to state, that mandate when professionals have to report child abuse and neglect. And then the second thing that really came into play was during the opiate epidemic was CARA. So this was passed in 2016, and it requires medical professionals to create a plan of safe care prior to hospital discharge for substance affected infants. And the state kind of defines what substance affected means, and to policies regarding when they must refer to DCFS. Okay, so those are the two major statutes, and then every state will have different laws.
Lulu,
So,
question.
yeah.
When it says affected,
Mhm.
does that mean, a FAS or NAS or something like that, or is it much more subtle and
Let's get into it,
subjective?
John. That's my next slide. You read my mind because I had no idea what that meant too. So, substance affected is kind of the key word here. And so, the Ohio Department of Family Services, because CARE requires you to define that, defines substance affected as a child under the age of 12 months who, this is substance affected babies, who has any detectable physical, developmental, cognitive, or emotional delay or harm, which is associated with their use of an of a legal or illegal substance. So that would be like FAS, or technically if they withdraw from using fentanyl, that would be considered like substance affected. Okay. And then based on that, per Ohio law, if the infant is substance affected, then DCFS has to screen in that notification. So if the baby is substance affected and someone makes a notification DCFS, they have to investigate essentially. And then, um, you know, if the again, if the and then they've decided the child is abused, because technically Ohio law defines like an infant who is substance affected, right? Because affected means that they've suffered some kind of actual injury as abused, is kind of the circular-ish logic, but how they define their terms. Now, contrary to popular belief, and this is me, I fully believed as well, nowhere in Ohio law is it defined that a positive prenatal drug screen meets the criteria for drug abuse. And I think a lot of times we make that logical leap that, obviously if your prenatal drug screen is positive before you deliver the baby, yeah, you were using drugs. It's a little bit semantics, like, yeah, you were using drugs, you were positive at delivery. And so therefore you would be positive if I tested you immediately after delivery. And we kind of have equated the two things in our head. But actually, Ohio law does not say that. Okay. If the only drug screen that is positive is prenatal and you don't have any concern that the child has been harmed in some way, technically you don't have to report. Okay. I think where some confusion comes into play was that there was this case law from a 2000 Ohio Supreme Court case called In Re Baby Boy Blackshear, where the question posed to the Ohio Supreme Court was, this is a mother who was using cocaine during the pregnancy, and she tested positive both prenatally and postnatally for cocaine. And the question posed to the court was, does her prenatal use of cocaine count as child abuse? And it was really kind of a fetal personhood type of question, to be honest. And what happened in that Supreme Court case was the court was like, we don't even need to answer this icky fetal personhood question. It's not territory we want to venture into. The baby tested positive after birth. Therefore, it was abused because it was positive after birth, right? And so that's kind of where I think people have conflated the two of prenatal and postnatal from Blackshear because the question posed to the court was whether or not the prenatal positive drug screen constituted child abuse. But really, the court did not answer that question. They just said the postnatal drug screen is positive, therefore the child is abused. Now, I'm just going to say this is case law, so it is the law, but it's not. I would just point out, even in Blackshear, the medical reasoning, the theory that your postnatal drug screen means that is positive and therefore you're abused is not in line with a medical understanding of abuse, right? And we are medical professionals. We should try and push that definition, right? Is my opinion. And because a, a reasonable person would not necessarily conclude that any child who has been substance exposed is de facto abused, right? Has suffered some kind of irreparable harm, right? And even in the Supreme Court case, there were judges that dissented and wrote, this is Judge Cook dissenting. This is his quote. The magistrate and trial court have assumed that a newborn who tests positive for an illegal substance is abused per se, rather than determining by clear and convincing evidence that this baby's exposure to cocaine caused or could have caused harm. The court below, the majority court, apparently proceeded from a generally accepted view that cocaine is harmful to its users. Right. And this is where this law comes from, this general view that drugs are harmful. And this is why I led my talk with what are the harms? What are the absolute risks of the harms? How bad are they? Because the public perception of the harms of drug abuse are way overblown compared to the actual medically demonstrated harms. I'm not saying there aren't harms, but people are literally out there thinking babies are going to be, IQ of 70, can't walk, going to be, need to be supported the rest of their lives. And that is not consistent with medical fact. So just to kind of reiterate, Ohio law does not mandate that you test a pregnant or birthing person or their neonate. Now, sometimes your hospital policy might say that, but that is not Ohio law. Ohio law does not mandate that you report a birthing person to DCFS solely for prenatal drug use. Okay, that is, again, oftentimes hospital policy, but that is not what Ohio law says. All right, and this is, again, this is Ohio law. When should you report child abuse or neglect? Based on facts that would cause a reasonable person. This is the law for medical professionals, okay? Not anybody. This is for medical professionals. No person based on facts that would cause a reasonable person with your level of education, you would have to suspect that the child actually suffered a physical or mental wound, injury, disability, or condition that indicates abuse or neglect. Okay. So again, this is the actual law. And I would just say that this is not how most hospitals choose to report. They just say, you're positive, we're reporting. Okay. So we have some leeway here in the law to change hospital policies when we report. And this is really important because a lot of physicians, including myself when I started this work, thought, you know what, I don't know. I'm just seeing this patient for the 2 times she even showed up to the hospital. She didn't get prenatal care. I don't know what's happening at home with her. Let me just make the notification. DCFS will sort it out. They'll decide if she's actually fit or not. They'll do the safety checks because I thought it was helping them. And I was wrong. Like sometimes those families, I think some families do benefit from a good DCFS worker who's really trying to help them and like get them into treatment and they're the true social worker, I think, spirit. But a lot of times DCFS is overstaffed, they're overwhelmed. They don't have time to really dive deep into a lot of families, and the approach can be very cookie cutter. And so DCFS, so we're relying on DCFS to decide if the family is safe and whether or not the patient really has a significant substance use disorder. Meanwhile, DCFS is relying on us, the medical providers, to decide that, right? I mean, your report to DCFS indicates to them that you do think there is a risk of harm. They don't see themselves as like the cleanup police for you to, investigate the patient. They're saying, well, the doctor filed the report, so they must think that there is a risk of harm, right? So we are each kind of deferring to each other to cast judgment on the family. And what oftentimes happens is no one has time to really investigate the family in a true, compassionate, helpful way. And the family gets put into this very cookie cutter, lengthy, and arduous surveillance process that does not actually help them. The legal standard, unfortunately, is fairly low for removal. I have seen patients who I think are doing amazing, and their kids are still removed because maybe 10, 15 years ago, they lost 3 kids already. The standard is very low, and there's a lack of nuance. So these are some of the again, I'm not trying to demonize DCFS because I have met people from there. I think they genuinely they're trying to do their best, but there are a lot of challenges. Okay, like they don't have a lot of resources. They're not medically trained. They have asked me questions like, can an epidural actually cause a fentanyl to be positive? This THC level is over 500. Doesn't mean the dad was high as a kite when the baby fell off the bed. They're not doctors. They don't know the stuff that we know. And so, unfortunately, when you refer someone to DCFS, there are intrinsic systemic problems that really just cause patients to be surveyed without being helped a lot of the times. And if you don't meet your DCFS plan within a year or two, you permanently lose your right to parent that child. And that is, as a parent myself, that is the most devastating thing I can ever imagine. Due to the reporting of infants who are exposed to drugs in utero, children under the age of 1 now represent the largest age group of any children in foster care. Okay, and I want you to think about that. The removals have increased 60% over the past decade, 3 times larger than removal increases for any other reason. And it is really solely because hospitals are reporting babies who are exposed to drugs in utero. And like I said, then when that happens, an investigation happens 85% of the time, and the parents cannot meet the case plan, and the children is removed. So this is a problem. And like any other problem in America, it is exacerbated by racism. Okay, so when you look at children who are Black, Native, their reunification rates are less, significantly less. And this is why a lot of people call DCFS a racist system, because there is racial disproportion in the children who are represented in foster care and the challenges faced by Black, Native, and really any marginalized population to restore custodial rights to their child is so overwhelming and has nothing to do with their desire or fitness to parent. Oftentimes the kids are removed. So you may start the investigation for drug use. The kids will be removed because of poverty. The impact of removal on the mom, I think we all know this. This is a profoundly traumatic event, and it changes people's DNA. They will not trust the healthcare system again. They will not trust the child welfare system again. They oftentimes fall into despair, I think, as anybody would if you were to permanently lose custody of your child, especially for reasons that don't even have to do with your personal faults, right? They were removed because your bio dad was abusive and you've left him already, but they were removed because you've dated two abusive men in a row, or they were removed because there's mold in the home and you can't afford to move out. To lose your child to something like that, you're gonna you're gonna give up. You're gonna increase your use of substances. You're not gonna engage. You're gonna drop out of treatment, right? Because you're doing all the right things and it still didn't protect your family. And these parents have PTSD, depression, anxiety, um, and it's a terrible, terrible thing that happens. So, what are things that we can do as providers? The first is, and just because this is the trigger for referrals at a lot of institutions, is to minimize biologic testing. All right. So always get patient consent before you test somebody because the consequences can be severe if they test positive. Don't test if it wouldn't change your medical management. I mean, we're doctors. We're here to medically manage the patient. If you don't think it's going to change your medical management, you don't need a test. You don't need a positive drug screen to refer to CPS. Like if you really think a patient cannot take care of her child, you can refer. You don't need to drug test them, right? If the drug testing should be for us to make medical decisions. Drug tests are not required by law on pregnant or birthing persons. They are not required by law on newborns. Okay, if any pediatricians out there, this one's really important. Okay, we test newborns a lot at my institution because I think there is some belief that it changes management. Very rarely have I seen it change medical management of a pediatric patient because by the time the result comes back, I mean, you're already doing the things that you need to do, And like, so what if they're positive for marijuana? We used to test used to test people for marijuana all the time, back when it was illegal. I was like 50, I was like over it was like 60 or 70% of our referrals were for marijuana alone, right? Since when does having a positive marijuana screen change anything medically? I mean, it's like, yay, I already knew you smoked pot. You told me you did. I'll watch a kid down the road to see if they ADD, but like, what's going to change in the first 30 days of life from a positive THC? Nothing, right? So don't test because if you test the newborn and they're positive by Ohio law, you do then have to refer. Okay. Don't report marijuana use. I think this hopefully is changing in institutions, but marijuana is legal, right? And remember, for the definition of substance affected, you have to have some kind of demonstrable harm. And there is no scientific consensus of harm from marijuana. I mean, we have things that we know marijuana can cause, like, ADD or maybe growth restriction, but you'll never prove that it's from the marijuana, And so you have no scientific consensus of what harm is from marijuana. So why would you report someone for using marijuana when the statute says to only report if a reasonable person concludes that whatever happened to the baby is from the substance? Still report it. And finally, I understand we are just one person. I have all these thoughts. Clearly, UH doesn't do all those things. We're just one person. But I think it is with the knowledge you have, it is our obligation then to push and promote policies that separate what I think is helpful, which is a plan of safe care, making sure that the baby and the parents have plans to have a healthy environment from a DCFS referral. Okay, the two are not equivalent. DCFS referrals does not mean that the parent is being showered with resources to help them. That is not a universal truth by any means. All right, so these are my takeaways. That parental substance use is not equivalent to causing some kind of demonstrable harm or injury to a child. Could it? Sure. Do we know that that's what caused it? It's very hard to demonstrate that. You're not legally mandated to test pregnant or birthing individuals or their babies. Drug testing is the number one trigger for a DCFS referral for neonates born in the hospital. And you can help people get healthier without DCFS. Oftentimes, I'm doing the same thing DCFS is doing, right? And then just push for policies that actually minimize child harm. Push for lead testing, push for safe water, push for, support for abused women. Like that actually minimizes child harm. And the change starts with each of us. And that is the conclusion of my talk.
And